So hi, Dr.
Hi,
Hima.
hi, Dr. Pragya.
Hi. So I've heard what you do and everything about the setup, etc. But would you want to introduce yourself?
Absolutely. Hi, everyone. I'm Dr. Hima. I'm an internal medicine specialist. That's my basic background. And then I did clinical genomics at Harvard. And since then, we have started our company called GenepoweRx, wherein we want to see how we can make genetics more useful in the clinical setting, be it cancers or be it chronic conditions. Because being an internist, that's something that I really wanted to pursue. So that's what we've been working on and providing help to any physicians who want to do it.
Right.
So, Dr. Pragya, would you like to introduce? You are the famous Dr. Pragnya Chigurupati. Go ahead, please.
Nothing so famous about this, but I'm Pragnya. I am a breast surgeon in AIG hospitals right now. But so basically, it covers everything in breast surgery as such, including benign cases, cancer cases, and reconstruction. So in short, that's me. But I guess something that I'm actually excited about is that I guess I can call myself the founder of the Breast Health Express, which is a mammogram bus that goes to rural India and screens women absolutely free of cost. And via the UC Breast Foundation that I run, we even treat those women. For example, anyone gets detected, absolutely for free. So I guess that's a part of what I do besides just the surgery part of it.
That's amazing, because especially in today's world, I think the awareness is something which is really important, and the cost inhibition. Maybe I can start off asking you, Dr. Pragya, in this particular current scenario, the way the lifestyle and everything is, what kind of cases do you see in breast cancer specifically in terms of, say, staging? Say, what age do they get, and what's their perception?
So until around maybe 5 years ago, most of the women who used to come to my clinic were around 45, 50 or older. But surprisingly, there's a new trend that I'm seeing in my clinic. So many women are between the ages of 30 and 40. And it's sort of shocking because when we actually go through, the demographics, the women are supposed to be about the age of 45, 40. That's the average Indian woman's age. But today it's more or less 30 to 40. And I'm guessing that's because of lifestyle and westernized diet, sedentary lifestyle, stress factors. There's so many issues that we can, put them against. But and the stages that they present with are also not all early stages. Right, so that puts me at a higher. They put, it's harder to treat these patients. And secondly, I guess awareness is increasing throughout the country. I will say, because there are quite a few people, at least the educated people, comparatively, I wouldn't say a lot, who are coming forward for screening. It's called opportunistic screening, as we all know. But I guess we still have a long way to go.
Absolutely. But I think that's where your foundation comes into play in increasing the awareness, especially in rural areas as well. Epigenetics, I don't think, is saving them either. Like they are being affected as well.
So, Dr. Hima, this entire concept of genetic testing, etc., is coming up in the recent past couple of years, right? So, what exactly is it, and can you explain why it matters in the context of breast diseases?
Right. Like you said, the concept of genetics is really gaining popularity in the current scenario. 6 years ago, when we first started off, it was quite new to people. People did not know at all. But thankfully, because of the amount of options in terms of drugs that you have for treatment, the treatment options, especially in cancer, awareness has gone up significantly. At least, like you said, in a particular population, there's more awareness that needs to be built. And it's showing very good results, be it in terms of screening or be it in terms of treatment, which you probably already know better than me. As to what all are the options available for current breast cancer treatment.
So, Dr. Hima, in medical practice, especially related to breast and ovarian cancers, now we know things like BRCA1, BRCA2 testing, and there are people asking me if they should get tested for that. So, how common are these inherited mutations in the Indian population?
So they are, so it again depends on one thing, which is how frequently are we even testing them genetically. That's the problem. The problem with Indian scenario is there's not a lot of testing that was happening till now. So we don't really know the logistics of it. But now that the genetic testing has become more affordable and also the awareness has gone up, there's more testing, there's more reflex testing, in fact. In that scenario, we are seeing quite a lot of BRCA1 and BRCA2, which are the high penetrance genes, and we call them the pathogenic or the likely pathogenic, which are more important, especially for you when you are planning the surgery or the further treatment options as well. So the number is going up. Now, does that reflect more testing, or is it that we've already had it from before? That's something, I guess, as the time passes and then we do more studies, with more physicians involved on board, is when we'll try to figure that out. But I'm pretty sure, like when you see your patients and when you're doing the history, especially, I'm pretty sure you come across, the hereditary or the familial type of cases, right? How often do you see that? And then usually what's the difference between both of them?
So, surprisingly, we see a lot of patients with, some sort of a family history of, some kind of a cancer. And the most common sentence or the statement that these patients make, especially those diagnosed with breast cancer, are, "Na ke pur cancer le do. I've never had a cancer in my life, or my family has never had a cancer of breast or ovarian. So why did I get it?"
Yeah.
Unfortunately, people don't realize that it's only 10% of all the breast cancers because of a genetic mutation. Now, talking about the word mutation, if you're tested and if there is anything wrong with until some mutation with any particular gene, that is called hereditary. But a family history, a strong family history, and many cancers in the family, but with no mutation, can be a familial breast cancer or familial cancer, and that can possibly be because of shared lifestyle habits or any particular thing like that. So again, I guess it's important for people to know that not everyone with a family history will have a cancer,
Right.
and not only those with the family history will have any kind of
Right.
cancer in their family.
And again, doesn't have to be breast cancer either, right? When you're talking about familial cancer, it can be anything.
Absolutely. There's
any
so
of those
many breast,
cancers.
ovarian, cervical cancer, peritoneal cancer, pancreatic cancer, prostate cancer. There's so many things that can be a part. So it's very important for every patient to, I think, as we all know, to understand the history of their family and then reach out to a doctor.
Right, right.
I think that's very important. So that brings me to the next question. What are the signs and symptoms in a family history that would be red flags saying, fine, this is the time to go and consult a doctor for the next step?
So yeah, that's family history is something which is very important when it comes to hereditary breast cancers. Like you said, it does contribute to some 10% of the cancers, but it's still quite significant. So normally, if there is anyone in the family who is less than 65 and has had a cancer, or a first degree relative, as in maybe on the mother's side somebody has a cancer, or maybe even on the paternal side, that's okay. And it doesn't always has to be breast cancer only. It can be any cancer for that matter. Somebody who's close, usually we like to ask if it's a first degree relative, because that's very important. The risk goes up significantly. But even if it's a second degree relative with some of these hereditary cancers like breast, prostate, or pancreas, in that situation we would really think that it's very important to check these individuals, maybe in terms of genetic screening, and also follow up with a gynecologist in terms of breast cancer screening or ovarian screening for that matter.
Yeah. Unfortunately, ovarian screening is so skewed that we just have to try and follow up as much as we can, because there are no screening mechanisms. But again, this is the context of only breast. However, knowing a family history is extremely important for that reason.
So, Dr. Pragya, let me ask you this. Since being a primary care, when I'm evaluating these patients, I have this question as to when should I send them for the next step in terms of evaluation and the next course of treatment for that matter.
So there are two scenarios here. One is a patient who has a family history but no cancer diagnosis, and second is the patient with a cancer diagnosis. Those women with a strong family history, I guess genetic counseling is very important first, and once they understand the pros and cons of actually getting tested, then they should go and get tested. Right? If they're okay to understand that I might be positive, so will I be okay to understand what to do with that result? And those women with the diagnosis of a cancer, I think it's important to get the screening done, the testing done as soon as the diagnosis is out, especially in those who fit the criteria that you mentioned earlier, because it takes around 4 weeks for the result to come. So in that time, we can at least sort of counsel them in a way that we can start some treatment and based on the stage of the disease, and then plan or change the rest of the treatment. We don't necessarily wait for the result to come because it takes 4 weeks, and that's a huge gap for the treatment to start. So I think it's important to diagnose it and get the testing done the day the breast cancer has been diagnosed, and then wait for the result to come and counsel accordingly.
Now, in terms of surgery, is it going to change your complete course of management if the test, say, for high penetrance genes like BRCA1 and BRCA2 comes out, maybe say before you're planning the surgery, would that change your outlook?
So today we're going towards the era of breast conservations, right? We don't have to do a mastectomy in every case. In such scenarios, we don't necessarily have to do a mastectomy today, right? Because there are studies that say that breast conservation, even in BRCA carriers, is safe enough. But where we have to start counseling is the other breast. Right? So we can do a risk reduction surgery because obviously the risk of the opposite side also increases. And if they're positive and we're putting them under the knife and anesthesia at some point, we also have to counsel them regarding ovarian surgery, removal of ovaries depending upon the age. So I guess in terms of surgery, yes, that matters, and we need to counsel them. Their decision is the final word. If they want to get it done or not, or if they want to just follow up, it's their decision. But from a doctor's perspective, I think counseling is
absolutely essential.
Important, yeah. So, Dr. Hima, we're talking about genetic testing right now. And in a country like India, how accessible and affordable is genetic testing? And what exactly are the financial barriers and the geographical barriers?
Genetic testing has become really affordable in current scenario. There was a time where it was extremely expensive, where only the rich could afford it. But now it's a common test, especially when it comes to the cancer screening, because we don't have to test the entire panel. It is much more accessible. But the problem here right now is not the cost. Really, the way the genetic testing has been projected so far, it's an expensive test. It's not in our financial budget. But then that's something that needs to be broken. The awareness has to improve. And in terms of geographical barriers, of course, the people who have more access to technology or to the tertiary centers, they of course know that there is something of this sort and that they can avail the benefit of it. The problem is with the rural areas wherein they don't know. In fact, there is a lot of stigma as well in even talking about it. Or even the knowledge for that matter that somebody had cancer. People don't even know the diagnosis. So that's something of a problem.
True, that's actually very true, because not many people are actually open to actually talk about it. In your experience, are these Indian families actually open to discussing the genetic results, even if it's a cancer patient or a non-cancer patient, just with a high risk? Are they actually responsive to you?
It's increasing, it's improving, I would say. It wasn't this good before. But then, yes, there is quite a bit of resistance because there is this taboo that, if you have cancer, then it's the end of the road. So that's the problem that commonly happens. And they're really scared. It's like, why do I want to know? What they don't understand is if it's not about, just knowing and getting scared about it. if you know there are options in terms of, say, increased screening, the treatment options,
And
there
you
are
take
so
it.
many things which will actually make sure that they live a full, healthy, long life.
Yeah.
So that's something that needs to be told more. But yes, there is significant resistance in terms of, it's scary for people.
True, true. So, Dr. Hema, if you actually had to give the importance of genetic
Mhm.
testing
Mhm.
in non-cancerous women with a high family risk,
Right.
what would your point be?
So the most important thing, the reason why your genetic testing is so important is because once you have the result, whether it's positive or negative, there is something that you can do about it in terms of beating it. So that's, I think, the number one advantage of getting a genetic testing done. Three advantages, I don't know if I can really tell you or not. One is you can beat the cancer, and I think that's the most important thing. And if you know if you are positive or negative, not only are you going to take care of yourself,
The rest of
but
the
then you
family.
can also help your close family members.
Yeah.
Right? So if you're screening them, maybe you can even form a group together and make sure that you're following up with the doctor, making those essential diet and lifestyle changes, which actually prevent, or maybe you might never even get it in your lifetime. So that's something that I really think that you should get the genetic testing done to know where you stand.
So, in this context, it sounds like you're talking about cascade testing. What exactly is cascade testing,
Right.
and how important is it for our families?
Cascade testing is specifically important when it comes to hereditary cancer risk, or familial, wherein in the family there are a few cancers, not necessarily breast, but any particular type of cancer. How you are helping each other is, first you have if there is an individual who has a cancer, breast or ovarian or any of the hereditary cancers, if they get it tested, they are positive for cancer and they have a high penetrance gene. We call high penetrance genes are the genes wherein if you have a mutation, then the chances of them having cancer is on the higher side. That warrants your first degree relative to get tested. And if they are positive, it needs to continue. Then the second person, maybe the mom or the sibling, they need to get tested, and then it just keeps going on from first degree relative to second degree relative and even third degree relative if it is positive.
Right.
So that way, if it is negative, then you just stop it. You don't have to continue anymore. It only continues whenever it's a positive scenario.
So now we're talking about patients getting tested when they come and they get a diagnosis of cancer.
Right.
But in those women who don't have the diagnosis but with a stronger family history, what is the role of gynecologists, and who are the first first responders in a way to all these patients, or breast surgeons for that matter, or any primary care physicians as a general physicians, etc. What is their role in genetic testing?
Their role is extremely critical. I think in current scenario, that's one of the most important thing. The doctor has to counsel their patient, especially I think the primary care physician, because by the time they get to you, they probably already have a diagnosis, maybe in the early stage or later on. Of course, it's very important for you also to counsel, but when it comes to the primary care physician or to a gynecologist, that's we should not only act as a physician but also as a genetic counselor to them, because of the treatment options, because of how it changes the treatment course. We would be the best judge and also give them the best advice in terms of the next follow-up. So we should be their patient advocate, their genetic counselor, and their physician as well.
Yeah. What I do with my patients, not the non-cancerous ones, and is that I explain them what genetic testing is, but I don't counsel them thoroughly myself. I actually send them to someone who's a genetic counselor who talks to them about the importance, and then it gets tested, because sometimes people just randomly keep getting tested, and they're like, okay, fine, now I'm positive, now I don't know what to do with it, and then anxiety builds up. So I think that step-by-step approach to even genetic testing is very, very important.
And when it comes from a physician, that gives a kind of authenticity and assurance to the patient, that it's okay, it's not scary, maybe I do need this test. Because when you are talking about it, then you're going to give them the actual medical evidence as to why is it that it
Yeah.
should be done, rather than just saying, oh, just get it done just for the sake of it.
Yeah.
So I think that's very important, especially because there are treatment options which
Yeah.
they should take
No
advantage
problem.
of, right?
Agreed.
So, Dr. Pragnya, let me ask you this. In terms of treatment, there can be a patient who has a non-cancerous lump versus a patient who actually has full-blown cancer. In terms of genetics and your other treatment options as well, how does genetics, how does that fit into your treatment protocol?
So the most common gene that we know of is BRCA in terms of breast and ovarian cancer, and let's stick to that subject. If in case it's just a woman with a high risk who turned out to be positive with this pathogenic mutation but no diagnosed cancer, in those women we can counsel them regarding risk-reducing mastectomy with a reconstruction.
Right.
And also the time to remove their ovaries, it's called an oophorectomy, the time to remove their ovaries and obviously put them on some kind of medication after that depending on their age. So these are the options that we give women with no cancer diagnosis. And like I mentioned, those with cancer diagnosis, we do talk to them about a risk reducing mastectomy on the opposite side, but also give them the opportunity of any surgery, although both are safe, that is a conservation as well as a mastectomy. But there are other medication also in terms of chemotherapy and targeted therapy that we can change based on their genetic result. If it's positive, then there's certain different kinds of medication and timing of surgery, the kind of medication and what overall matters. And so I think that's the reason it's very important to for these Indian patients, or not Indian patient, any patient for that matter, to get tested for BRCA and if it's then screen themselves from a much earlier age to diagnose any early stage of cancer, and then God forbid, but whatever happens, happens.
I think the BRCA1, BRCA2, like you rightly said, is the most popular one. People know about it as well, and that changes the treatment protocol as well, right? In terms of the availability in our Indian, hospital systems, because there are certain medications which you can use which are targeted, right? How is the patient's approach as well as the availability, the affordability of these newer drugs which can be?
With regards to surgery, I think it doesn't really cost as much extra unless and until they want a reconstruction, which yes, there is a little bit of an extra cost to that. Whereas in terms of medication, those medication that we need for these patients are not excessively out of range. So I think it's an affordable option that patients have. And testing is something that people are going forward, especially because it sort of scares them about the kids getting this, their kids getting the disease. So if not for themselves, they get tested for their kids because they can get tested if they turn out to be positive. But financially, I don't think it really changes things drastically. So people are willing to do this a lot more than you think they are. But again, since we're talking about finances, are insurance companies actually covering the entire genetic testing and treatment if in case they're positive, or risk reducing surgeries? Do insurance companies cover this today?
This is something, I guess, which is new for them as well, and I guess it just needs to slowly get into the system that it does make a significant difference in a patient's life, and it's very critical for the treatment. So I guess at some point it might get in. At this time, actively, I would say no. Now, talking about the treatment, I was just thinking, now that you asked me about insurance, and in terms of practically, when you actually treat the patients and when you put them on these targeted treatment options, of course, chemotherapy and radiotherapy, those are the mainstay as well, along with the surgery, the combination of three. How is the outcome? Has it changed?
The risk is slightly higher, obviously, in terms of BRCA positive patients and like the risk of recurrence, etc. It is slightly higher than those with no BRCA mutation. So we just keep them on a follow-up like all breast cancer patients,
Right.
and we do obviously follow up, them with more aggressive imaging if required, depending upon the age of the patient. And obviously, surgical options are different, and medication-wise, it's pretty much the same. We don't really change too much in that.
Right.
But we make sure the cancer patients come back to us every 6 months, or if not that often, if not that, at least like 5 to 6 months gap, and then get imaging every year. It doesn't necessarily mean a PET scan.
Right.
Just basic investigations are also enough.
Do you think the PARP inhibitors or any of these targeted therapies, is it increasing their,
There are studies to prove that they have increased. There is a survival benefit.
There is
a survival benefit.
There is a significant survival.
So that's the reason most of the patients do get this, and that's why they do benefit. Unfortunately, even the NGOs and most of the non-profit organizations today are not testing them for these genetic tests, and that's something, I guess, if it is subsidized cancer treatment or free treatment, as they say, I think that should be a part of the protocol as well.
Absolutely, because the traditional treatment modalities stay. But if you're saying, having seen these patients, that if their side effect profile is on the lesser side with these medications and the outcomes are much better, then why not?
They should get tested, yeah.
They should, right? So I guess now the question is, how should we take this forward? You being one of the frontline workers for, the cancer awareness, how should we take it forward?
I think we are quite a few steps behind as yet, honestly speaking. There's a long way to go. I think first people should be aware of the fact that there is something called breast cancer, and you'll be surprised to know how reluctant women are to come and get themselves clinically examined, and that's something I'm learning through the Breast Health Express. So I think the first step is just creating awareness of something called breast cancer, breast diseases, and then we'll have to get to the concept of family history and just the entire genetic mutations and testing for them, genetic counseling. There's a long way to go, and it's not a single person that can do this, and it has to be all the physicians involved in the entire process.
Multiple factors, right?
Yeah, cost, absolutely.
That it is cost effective, you can get it done, anyone can get it done, and also the resistance needs to go
absolutely. A lot of counseling required. Yeah. So Dr. Hima, what are the changes in the next 5 years in India with regards to the testing, detection, and treatment of breast cancer and genetic mutations?
I think in the next 5 years, there's going to be significant changes, Dr. Pragya. Already the PARP inhibitors are in, which are being extensively used by the physicians, and you use the PARPs based on their BRCA1 status, right? Along with that, now that the somatic testing, which is basically the breast cancer tissue testing after the surgery is done to see if there is some other medication that can be added, there are more drugs being added to those mutations, like PIK, 3CA. There are all this tumor burden that we look at, and then based on that, there are these drugs which are immune checkpoint drugs, which work fabulously. The outcome has been great in terms of that. And there's so much more research going on worldwide with all these trials going on. The patients are enrolling, and newer mutations are being checked out of those somatic testing panel. So in the last 5 years, we've had so many drugs already come up. The next 5 years, since the research has really picked up pace, I think it's going to be just like your cholesterol pill or your diabetes pill, that you just take a cancer pill, and then maybe it's a little over exaggeration, but hey, who knows, right?
Yeah,
but
absolutely.
I think in that actual reality to actually kick in, there's a lot of work that needs to happen as to some kind of the foundation to tell the patients and the physicians also to be more aware of all of these changes. So I think, Dr. Pragya, you should talk about that in terms of foundation. How do you think we can bring about these changes?
So again, it comes down to the concept of awareness, bringing about awareness and things like that. And I've told you about the foundation that we run. It's called UC
Right.
Breast Foundation, and so via what we do is we have a bus which is called a Breast Health Express. We take it to rural India. And not only do we screen, but we also conduct awareness camps for these women. We start off with the basics of what breast diseases are, and then we jumped to the next step of what screening means, and then we screen them. But I guess in the near future, we should also introduce the concept of what genetic testing is, especially to the younger ones.
Right.
Even in the rural areas, also there are a lot of educated people today, right? The children, and they are going and studying. So I guess they will understand the basics. So I think we should incorporate that as well in this foundation. I can't
Right.
talk for all the foundations, obviously. So, but what we do today in the UC Breast Foundation is we do those patients who come to us, we do screen them for these mutations as well. Again, case to case basis, not everyone. So again, that's free of cost. So that is included in our foundation right now. But the next step would probably be bringing about awareness about the same.
That's amazing. That's really good news, and maybe we'll make a difference in the world of cancer. Maybe beat it all together. Right?
Let's hope.
Let's hope. Let's hope.